Hello, I'm James M. Hughes, Professor of Medicine and Public Health at Emory University in Atlanta, Georgia. I'm pleased to have the opportunity to speak with you today on emerging microbial threats, issues, challenges, and opportunities at the human-animal ecosystem interface. I have no conflicts to disclose related to this presentation. Here is an outline of my presentation. I will first identify factors contributing to infectious disease emergence and spread. I will then discuss some recent examples of disease emergence from animal reservoirs. I will describe challenges in zoonotic disease detection and response. And finally, I will review current efforts to strengthen global capacity for early detection, response, and control of emerging infectious diseases. This is a slide showing the crude death rate for infectious diseases in the United States during the 20th century. You'll notice here early in the 1900s, there was a very high death rate. Interestingly, you'll see that the first city in the United States to begin to chlorinate drinking water did so in about 1910. You see the mortality impact associated with the first influenza pandemic of the 20th century here in this dramatic spike. And following that, you see a rather dramatic decline preceding the introduction of penicillin and a number of very effective vaccines. The mortality rate decreased up until about 1980, when you'll notice that the mortality due to infectious diseases in the United States began to increase again. This was attributable in part to the AIDS epidemic, but other major contributors were pneumonia and bloodstream infection. Because of the success during the 20th century in the United States, and indeed many other developed countries, in reducing infectious disease mortality, a number of people began to think that infectious diseases were controlled. And this is an example of a quotation from a Nobel laureate, Sir Macfarlane Burnet, who in 1962 wrote, "One can think of the middle of the 20th century as the end of one of the most important social revolutions in history, the virtual elimination of the infectious disease as a significant factor in social life." Ponder that quote for a moment. That is a dramatic example of what we today refer to as complacency about infectious diseases having been largely controlled. The Institute of Medicine of the U.S. National Academies convened an expert committee in the early 1990s to focus on the issue of emerging infectious diseases. This expert committee that was co-chaired by another Nobel laureate, Dr. Joshua Lederberg, and co-chaired with Dr. Robert Shope at Yale University at the time, made a number of important contributions. One, they provided a definition of emerging infections as new, re-emerging, or drug-resistant infections in whose incidence in humans has increased within the past 2 decades, or whose incidence threatens to increase in the near future. That's a very broad definition, and it's interesting that even at that time, it specifically included drug-resistant infections. Over the last 20 years, there have been a number of dramatic examples of emerging and re-emerging infectious diseases. This slide just shows some of them. I hope all of you can see one or more disease on this slide in which you have a particular interest. Some of the more recent ones are highlighted in the yellow type and the black boxes. You'll notice that this is a global problem. You'll notice, I hope, that many of these are either vector-borne or zoonotic diseases, diseases that have crossed species. And we'll come back to that issue later in the talk. A number of these diseases also share a propensity to drug resistance on the one hand, and others represent diseases for which we lack effective countermeasures. The media enjoy covering these diseases. A number of names have been used that capture the attention of the public. Superbugs for drug-resistant organisms, hemorrhagic fever, Ebola, an ongoing problem currently, certainly captures media attention. Spanish flu, the reference to the first influenza pandemic in the 20th century, mad cow disease, the new AIDS of the Americas, brain-eating amoeba, flesh-eating bacteria, XDR tuberculosis, extensively drug-resistant TB, and the term pre-antibiotic era is often used given the current crisis in antimicrobial resistance. The Institute of Medicine Committee in the early 1990s, the cover of the report is shown on the left, identified 6 major factors that the committee felt were important in contributing to disease emergence and reemergence. Changes in human demographics and behavior, advances in technology and industry, economic development and changes in land use patterns, international travel and commerce, the dramatic increase that we've seen in the volume and speed with which humans, animals, and commodities can move around the world. Microbial adaptation and change in response to selective pressures. Drug resistance is a good example of the impact of that particular factor. And breakdown of public health measures as a result of the complacency that we've talked about. And we've seen that at the local level, at the national level, and indeed at the global level. Early in the 2000s, the Institute of Medicine reconvened another expert committee to focus on the issue of emerging infections, and they produced in 2003 the report shown in the upper right, Microbial Threats to Health. That committee, again, co-led by Dr. Letterberg and Dr. Margaret Hamburg, who is currently the U.S. Commissioner of the Food and Drug Administration, validated the original 6 factors and added 7 more. Changes in human susceptibility to infection, climate and weather changes, changing ecosystems, poverty and social inequality, war and famine, lack of political will, and sadly, the intent to harm, bioterrorism. I will illustrate a few of these factors briefly for you. First, the changes in human demographics and behavior. The slide on the left is a photo taken in Dhaka, Bangladesh, a mega city. The slide in the upper right is taken in a wet market in South Asia, a live animal market there. And on the lower right, you'll see an example of people using a contaminated surface water source in sub-Saharan Africa. Keep the photograph of Dhaka in mind for a moment. As you know, there are 4 routes of transmission of infectious agents. First, by contact, direct person-to-person spread. Secondly, common vehicle, contaminated food, contaminated water, contaminated blood or blood products are examples. The vector-borne route, and finally, the airborne route. Now, if you think about the picture of Dhaka and you pretend for a moment that you're a microbe, I think you would feel that regardless of your preferred mode of transmission, that your chances in one of these dense urban megacity settings of spreading are quite good. Trends in global population. The global population is increasing. As you know, we recently passed the $7 billion people number. Almost all of this growth, population growth, as you can see in the green portions of the bars in this slide, is attributable to less developed countries. At the same time, we've seen a dramatic increase in the number and location of these megacities. Megacities are urban agglomerations of 10 million or more people, often with urban slums and peri-urban slums surrounding them. In 1950, there were only 2 of these, and both were in the developed world. By 1975, there was just 1 more, and it was located in the developing world. However, by 2007, there were 19, 3/4 of which were located in the developing world in low-income country settings. And by 2025, this projection predicted as many as 27, with nearly 80% being located in low-income countries. If you look, you may find other projections showing either even higher numbers in years after 2025. This contributes to another interesting pattern, and that is world meat consumption from 1983 projected out to as far as 2017. And with the population increases, not surprisingly, the demand for dietary meat is increasing. And again, you'll see that the increase is attributable almost exclusively to that occurring in low-income developing country settings, shown in the red line. You can imagine what this means in terms of the increased intensity of human contact with livestock and other sources of dietary meat products, such as bushmeat. International travel and commerce, I've mentioned that already. This is a slide just depicting the global aviation network on a typical day, and the red lines illustrate the flights that occur. You may have seen that slide before, but take a look here at a companion slide, and this is showing a snapshot at a moment in time of commercial ship traffic, the location of ships around the world. These ships are, of course, carrying people. They're carrying, in some cases, animals, and they're carrying commodities, including food products and other commodities all over the world. Microbial adaptation and change and its relationship to drug resistance. A relatively recent, fairly dramatic example of the emergence and spread of multiply drug-resistant organisms is provided by the experience with NDM1, or New Delhi metallobeta-lactamase 1, in Enterobacteriaceae. This gene refers pan resistance to most currently available antibiotics. Actually, it's a broadly active beta-lactamase that's effective against all available antibiotics except tigecycline and colistin. This is present in a clonally diverse array of bacterial strains. The gene is found primarily on plasmids and is transferable. And some of these infections have been associated with what is called medical tourism. This slide from a LANCET infectious disease article in 2010 shows the distribution of NDM1 producing Enterobacteriaceae strains in the United Kingdom on the left, and Bangladesh, India, and Pakistan. The strains in the United Kingdom were isolated from patients, the majority of whom had medical procedures in India or other locations on the Asian subcontinent. Further studies in New Delhi, looking at the possibility of environmental contamination associated with this organism, involved sampling of 171 surface water sites, and 50 tap water samples were taken. Organisms with the NDM1 gene were found in 51 or 30% of the surface water and 2 of 50 or 4% of the tap water samples. In addition, the NDM1 gene was found in 11 species of bacteria in which it had not previously been seen in that study. This is a good example of why WHO, for the first time in the year 2011, focused the theme of World Health Day on antimicrobial resistance. The tagline was "Combat drug resistance, no action today, no cure tomorrow." And I think it's that "no action today, no cure tomorrow" statement that captures the urgency of this particular threat. Another important factor contributing to disease emergence is poverty and social inequality. The photo in the upper left was taken in a clinic in Haiti prior to the 2010 earthquake, illustrating the density of the patients awaiting care in that clinic. In the lower left, a photograph taken in a peri-urban slum just outside Mumbai in India, and on the right, a typical favela in Rio de Janeiro. On January 12, 2010, Haiti experienced a devastating earthquake in Port-au-Prince and around much of the country. A fierce earthquake did indeed rock Haiti with high mortality and massive destruction. 6 months into the recovery effort, Nigel Fisher, who was at that time Deputy Special Representative of the United Nations Secretary General in Haiti, said, "What hasn't happened is worth noting. We haven't had a major outbreak of disease. We haven't had a major breakdown in security." That was good news at the time, but it could be interpreted as another example of the complacency that we have already talked about related to infectious diseases in the United States. 3 months later, sadly, Haiti experienced the onset of a devastating cholera epidemic, which to date has been responsible for well in the excess of 650,000 cases and well over 8,000 deaths, and continues to pose challenges to clinicians and public health officials in Haiti. Another factor, lack of political will. Here's an example taken from human disease, polio. Obstacles keep eradication out of reach. This is a map from a newspaper article in the Atlanta Journal-Constitution in 2004, showing what happened following a decision by religious leaders in northern Nigeria to cease polio immunization campaigns in the area because of concerns about the motives of the campaign and possible problems with the vaccine. As a result of that decision to stop those immunizations, polio spread from northern Nigeria and reinfected over 20 different countries in West Africa, East Africa, the Middle East, and as far away as Indonesia, where the disease had previously been eradicated, greatly complicating the challenges related to global polio eradication. More recently, we've seen other challenges to that eradication effort. Another dramatic example of the impact of lack of political will was provided for an emerging zoonotic disease involving the early cases of what came to be called severe acute respiratory syndrome, or SARS, which emerged in South China at 2 different locations in Guangdong province in November of 2002. However, it wasn't until February of 2003 that China reported 305 cases of illness involving an acute respiratory syndrome in Guangdong province to the World Health Organization, WHO. SARS in 2003 indeed was a serious global microbial threat. This is one of the heroes of the early response to SARS, Dr. Carlo Urbani, who at the time was president of the Italian chapter of Doctors Without Borders and was working for the World Health Organization as a physician in the French hospital in Hanoi, Vietnam, where in early March of 2003 he was called to evaluate an American businessman who had fallen ill with what was described as, quote, a bad case of influenza. The patient had been in a hotel, the Hotel Metropole in Hong Kong, a few days prior to the onset of his illness. Dr. Urbani realized that the patient did not have influenza, but probably had a new highly contagious disease. He notified WHO, implemented infection control precautions in the French hospital, and began an investigation. A few days later, he became ill. He had an illness characterized by fever, shortness of breath, myalgias, muscle pains, low platelet count, and low white blood cell count. He was hospitalized in Bangkok, Thailand, and unfortunately died. A respiratory specimen from him was sent to CDC and actually was the source of the virus that was recognized at CDC later in the month of March. Further investigation of this patient revealed this rather dramatic scenario. A physician indicated in box A, who was working in Guangdong province and who had cared for hospitalized patients with this severe unexplained illness, went to Hong Kong for a wedding accompanied by his wife. He was ill on arrival at the hotel, the Hotel Metropole, and he went straight to his room on the 9th floor where he stayed for 24 hours. By that time, he was seriously ill, recognized the need to be hospitalized, and was hospitalized in a local hospital in Hong Kong, and unfortunately died. Although he stayed in his room the whole time he was in the hotel, he somehow managed to transmit his infection to approximately 10 other people who were guests at the hotel, most of whom stayed in other rooms on the 9th floor. Those individuals continued their journeys, subsequently became ill, and were hospitalized at hospitals in Hong Kong, in Vietnam, in Singapore, in the US, in Ireland, and in Canada, where they transmitted their infections to healthcare workers, family members, and other close contacts. This one episode, this scenario in the Hotel Metropole, was responsible for much of the early global dissemination of SARS coronavirus. The response to SARS illustrates the importance of public health surveillance. And I thought it was worth spending a moment on the definition of public health surveillance. It is the ongoing systematic collection, analysis, and interpretation of outcome-specific data. But it does not stop there. The data must be closely integrated with the timely dissemination of the data to those responsible for taking public health action to prevent and control disease or injury. You'll often hear public health surveillance referred to as data for action. Because no countermeasures were available, no drugs, no vaccines, and in the early days, no rapid diagnostic tests for SARS coronavirus, the response relied on tried and true public health measures: disease surveillance, identification of ill individuals and isolation of them, and quarantine of individuals who had been exposed to infected patients but had not yet become ill. It's important to appreciate the difference in the terms isolation and quarantine. Isolation applies to people who are ill. You can see an individual hospitalized in Hong Kong who's on the TV set here being visited by his wife, who is in another room but is able to communicate with him while he is in isolation. In contrast, quarantine applies to people who have been exposed but are not yet ill. And these individuals are nurses in a hospital in Taiwan who have been placed in quarantine for observation following their exposure to infected patients, and they have not yet become ill. These measures are usually voluntary, but they can be mandatory. legal quarantine authority does cover both isolation and quarantine tools, and it was these tools that were effective in stopping the local and global spread of SARS. Further investigations revealed that SARS was an example of an event involving cross-species transmission. The electron micrograph in the middle is a depiction of SARS coronavirus. You can see the crown-like effect around the periphery of the viral particle, which gives rise to the coronavirus name. The source for the patients of their infection was exposure to infected animals in live animal or wet markets, an example of which is shown here. The Himalayan palm civet had a high prevalence of infection in these settings. Other exotic animals, including raccoon dogs and Chinese ferret badgers, probably played some role, but the prevalence of infection in those species was lower. However, further investigations revealed that the palm civet was not the original source of the virus in nature, and that actually the virus originated in Chinese horseshoe bats, which then subsequently infected the palm civet and the other exotic animals in these market settings. This slide reminds you of the factors in disease emergence that I've already discussed. The ones in bold are those that we felt contributed to the emergence of SARS. So you can see that all 6 of the original factors identified by the 1992 ILM report were involved. And in addition, 2 of the factors identified by the report issued in 2003, Changing Ecosystems and Lack of Political Will, also played important roles in the emergence and spread of SARS coronavirus. Here's a quotation from Dr. David Heyman and Dr. Ganel Rodier, who were 2 of the leaders of the WHO aggressive international response to SARS. The SARS experience made one lesson clear early in its course. Inadequate surveillance and response capacity in a single country can endanger national populations and the public health security of the entire world. The experience is a reminder of the importance of vigilance in the early detection and response to emerging infectious diseases. The alert physician plays a critical role, often the alert veterinarian, the alert pathologist, the alert laboratorian, particularly alert microbiologists, play very important roles in recognition and response to these challenges. The alert research scientist has an important role to play, and the alert public health official obviously has a very important role to play in recognition and response. Now we'll focus a little bit more on issues related to cross-species transmission. Here's a quotation from a LANCET infectious disease article in 2011. Tracing the origin of HIV has confirmed that viruses can jump from one species to another after a very long period of no transmission and adapt rapidly. So it's important to remember that HIV infection was initially a zoonosis, but the virus obviously has adapted very well to humans and spread from person to person around the world. Here's a schematic diagram developed by Nathan Wolf and his colleagues and published in Nature in 2007, depicting 5 stages of cross-species transmission, and we'll go briefly through part of this slide. Rabies is a good example of a disease of animals that spreads to humans, resulting typically in only primary infection in someone with an exposure to a rabid animal. Now, there have been examples of transmission of rabies from index infected patients to healthcare providers or family members, and occasionally by transplanted organs. But in general, the rabies is a problem related to the one individual that acquires it from an infected animal. Now, if you move to the right, you see Ebola, which at the time this slide was made, was felt to be associated with primary infection and then limited outbreaks, is so-called stage 3. However, the ongoing severe global threat posed by Ebola hemorrhagic fever in West Africa has changed this in the sense that Ebola in that setting is now responsible for a stage 4 long outbreak of disease. And here on the right is HIV and a depiction of the fact that it made it all the way to stage 5, where exclusively human-to-human transmission is responsible for continuation of the pandemic. Here's a slide of an article by Mark Woolhouse and Eleanor Gaunt, published in 2007, reporting the results of a systematic literature review of 1,399 human pathogens, 87 or 6% of which were reported after 1980. 58 or 2/3 of these were viruses, and most of those were RNA viruses. They found that literature reports from around the world, and they found that the majority of these evolved emergence from animal reservoirs. A follow-up paper by Kate Jones, Peter Daszak, and others in Nature in 2008 reviewed 335 emerging disease events from 1940 to 2004. They also noted a non-random global distribution of these outbreaks and reported that 60% originated in animal reservoirs and 72% of those originated in wildlife. And they further identified certain geographic hotspots for disease emergence. Over the years since 1990, there have been a number of examples of zoonotic disease epidemics, including SARS, shown here, and avian influenza, H5N1 avian influenza. The size of these circles here represents a depiction of the economic impact of some of these epidemics, SARS being dramatic at US $40 to $50 billion estimates. Not shown on this slide is the 2009 H1N1 pandemic, which, if it were shown, would be a circle at least as large as SARS and probably somewhat larger in the $60 to $70 billion range. This slide shows two individuals in the United States who played important roles in emphasizing the importance of this issue of cross-species transmission. A quote from Dr. Jim Steele, who sadly passed away just last year at the age of 100. But he had a very distinguished career serving as veterinary public health division chief at CDC and later as Assistant Surgeon General for Veterinary Affairs in the U.S. Public Health Service. He wrote, "Human and animal health are inextricably linked. They always have been. They always will be." Another leader in recognition of the importance of this problem was Dr. Calvin Schwabe, who was a professor of veterinary medicine at the University of California in Davis. These slides are here to show the importance that individuals who are champions of movements can play in drawing attention to them. Here's a quote from the cover of LANCET in December of 2012. "Endemic and enzootic zoonoses cause about 1 billion cases of illnesses in people and millions of deaths every year, and emerging zoonoses are a rising threat to global health." This leads to individuals emphasizing the importance of the so-called One Health concept. And this is important in that it stresses the importance of the interfaces between humans, animals, both domestic animals and wildlife, and environments or ecosystems. It's at these interfaces that we encounter much of the infectious disease emergence and reemergence experienced over the last 20 to 25 years. Concerns about cross-species transmission lead people to try to make predictions. There are geographic hotspots. Rainforests and megacities in particular come to mind. There are hot animal reservoirs, bats, pigs, and in the US, prairie dogs have played a very important role. They're hot settings, and we've talked about wet markets. They're hot vectors, and here's an Aedes albopictus mosquito, which is a particularly aggressive day-biting mosquito found in much of the US today that's capable of transmitting an array of arboviruses. And then there are hot vehicles, and bushmeat is one that has been getting more and more attention in recent years, and often plays a role in the initial human infections at the beginning of Ebola virus epidemics. One thing that we've learned over the years is that when you encounter a new infectious disease, it's important to be careful about how you name it. This is a slide and a photo from an article in Science in 2009 in the context of the H1N1 influenza pandemic, pointing out that swine flu names evolve faster than swine flu itself, and you can see a number of the names that were initially used. It's important to remember the potential for names to be stigmatizing. And for example, you see Mexican flu here, which understandably the Mexicans did not appreciate as one of the early terms that was used by some. And swine flu, in fact, is not appreciated by individuals who work in the pork industry. So it is important to be sensitive to decisions about how to name a new agent. In the United States, the U.S. Agency for International Development, USAID, has been a leader in providing support for research efforts to detect and respond to emerging zoonotic diseases. 5 years ago, they launched an Emerging Pandemic Threats program. It's a 5-year, $400 million effort. It was launched in fiscal year 2010. And it focuses on early identification of and response to dangerous pathogens in animals, especially in wildlife, before transmission to humans. A team led by UC Davis has been responsible for the PREDICT component of this emerging pandemic threat program. This effort seeks to capitalize on opportunities to prevent, detect, and respond to the emergence and transmission of zoonotic diseases. Fairly typically in emerging disease outbreaks, the outbreaks are not recognized until humans seek medical care, depicted in this gray line here. But prior to humans seeking medical care, humans become ill. Prior to that, humans are exposed to the agent. Prior to that, in some cases, animals with the infection have become ill and seek and have sought veterinary care. Earlier than that, they have clinical signs, and earlier than that, they have exposures to whatever the agent are. Part of the thrust of the Emerging Pandemic Threats program is to try to shift agent recognition from out here back to the left, at least to detection of potential human threats while still resident in animal populations. Some, including Dr. David Heyman, who I've mentioned, have emphasized the importance of shifting back even further to the left on this slide to try to address the root causes of emergence of these diseases, which are often poverty and war and civil strife. So what does the future hold? This is an article written a little over 10 years ago by Don McNeil in the New York Times. The headline is "The Next Generation of Diseases Are in Hiding Somewhere." I've been often asked, what do I think the future holds? And I think it holds yet another influenza pandemic. That day will come. More and more challenges associated with antimicrobial resistance, international foodborne disease outbreaks, the ever-present threat of the reemergence of urban yellow fever in Latin America, or the potential for the spread of um, urban yellow fever to other parts of the world, for example, Asia, where competent vectors exist, but unfortunately the virus is not present. Beyond the scope of this talk, I think we're going to continue to be surprised by the role that infectious agents play in chronic disease, and in fact the role of the microbiome in chronic diseases. And then finally, we know that we're going to continue to confront unexpected disease events and the emergence of new agents. Beginning in 1997 in Hong Kong, which experienced a localized, fortunately, H5N1 influenza pandemic or epidemic in humans, attention focused on concerns about avian influenza as being the potential source of a new influenza pandemic strain, and a lot of attention was paid to H5N1. This is an important quote that I like. Something said by Dr. Ted Eickhoff, who's a very eminent infectious disease physician in the United States, who wrote back in 2005, "At the same time, I am somewhat bemused by the number of experts who appear regularly in the public media and predict with virtual certainty that H5N1 will be the next pandemic strain, and soon. Lifelong students of this disease are much more humble about their predictions." And he was right. In 2009, as you will recall, a pandemic strain of H1N1 influenza emerged. Here's the term swine flu, used in a headline reporting the declaration of a national emergency. There were a number of surprises associated with that pandemic emergence. First of all, it was not an avian influenza strain. It was an H1N1 strain. It originated not in South or Southeast Asia, where many had felt the next pandemic would begin, but rather in Mexico. It was recognized not in Asia, but in North America. It spread very rapidly. It had an unusual age distribution for influenza, a dramatic impact on young adults, for example. Comorbidities were important risk factors, particularly pregnancy and chronic diseases. Transmission persisted throughout the year and involved transmission during the summer, which is obviously unusual for influenza. And it was amplified dramatically in schools and summer camp settings. Here's a photo of Dr. Margaret Chan pointing out that at the time, sometimes though we are just plain lucky, this has been the case with the H1N1 influenza pandemic, which was not as severe a pandemic as many people had been predicting. All of these experiences provide reminders emphasized by this quote taken from the 2003 Institute of Medicine report. A robust public health system in its science, capacity, practice, and through its collaborations with clinical and veterinary medicine, academia, industry, and other public and private partners is the best defense against any microbial threat. I will now talk about some of the opportunities that currently exist to detect and respond effectively to these emerging diseases. This slide depicts the cover of the old international health regulations issued in 1969 and the current version, which has the force of an international treaty endorsed by, at the time, all 194 WHO member states when it was issued in 2005. This is referred to as International Health Regulations 2005 or IHR 2005. It updates the previous regulations. in the context of today's globalized world. It places an emphasis on timely reporting of diseases, sharing in a very transparent way information on disease challenges that are occurring in individual countries, and places a particular emphasis on the importance of strengthening laboratory capacity. The goal of IHR 2005 is to prevent the international spread of disease. WHO has emphasized that it should not be considered as a surrogate for or a replacement for national surveillance and response systems. But it does require that all member states must be able in a timely way to detect, assess, report, and respond to public health risks and emergencies of potential international concern. Now, obviously, in today's world, the ability of different countries to do that in an effective, timely way is highly variable. The report discusses public health emergencies of international concern. The H1N1 pandemic was the first of those, and since the issuance of IHR 2005, and now we're in the midst of the second with the Ebola viral disease epidemic in West Africa. The report contains a decision instrument for countries to use. It requires immediate notification of even one case of smallpox, polio, SARS, or influenza caused by new subtypes. And it provides guidance for the need for notification for a number of other diseases, including cholera, pneumonic plague, yellow fever, viral hemorrhagic fevers, including Ebola, Marburg, and Lassa fever, and others, West Nile fever, and other diseases of potential national or regional concern, such as dengue or Rift Valley fever virus infection. A number of lessons have been learned over the years by responding to a number of these emerging disease challenges. The importance of vigilance I've already emphasized. The importance of strengthened surveillance and public health laboratory capacity. The importance of better predictive capability. Multidisciplinary partnerships in the spirit of the One Health movement, improved coordination, proactive communication, and avoidance of stigmatization. We've talked about transparency and sustained political will, critically important at the local, national, regional, and global level. And there's clearly a need to address research, training, and education priorities. And you see all three of these topics being emphasized now during efforts to respond to the ongoing Ebola crisis. So in conclusion, trends in many of the factors that we've discussed appear to favor the microbes. So new threats will emerge. Many will be zoonotic. Vigilant healthcare frontline healthcare workers will continue to have a critically important role in recognition of emerging diseases. For clinicians, it's important to remember the importance of obtaining travel, work, hobbies, and animal contact histories. You see travel and animal contact being emphasized now in the Ebola response. Surveillance is critical to achieving public health security. Improving national and international surveillance capabilities should be priorities for national health and security policy, as well as strengthening clinical and public health systems around the world. Again, a lesson being driven home dramatically now by the ongoing Ebola epidemic. Helping individual countries improve their surveillance capacities will benefit all countries. Another dramatic example reinforced by the current Ebola experience. Some recent examples involving vector-borne diseases and zoonoses. First, in the United States, a West Nile virus, which was introduced into the U.S. in 1999, a big epidemic year in 2012. H3N2 influenza variant associated with swine exposures in the U.S. Hantavirus pulmonary syndrome, a big outbreak in Yosemite National Park recently, and the emergence and first detection of Heartland virus, phlebivirus, recently detected initially in our state of Missouri. At the international level, we've experienced MERS coronavirus in the Middle East, H7N9 influenza, chikungunya throughout the Caribbean was spread to Central America and North America and areas of South America. And then currently, again, the Ebola virus disease in West Africa. A critical lesson of all this should be to expect the unexpected and to avoid complacency at all costs regarding infectious diseases. And this is the final slide. It's a depiction of the CDC journal Emerging Infectious Diseases that I would call to your attention. I hope many of you are subscribers. It is a free open access monthly publication that's peer reviewed and distributed by CDC and easily available at no charge on the CDC website at www.cdc.gov/EID. Thank you very much for your attention, and good luck in your ongoing efforts to detect and respond to infectious diseases. Thank you very much.